Good evening, everyone. I am Dr. Bruce Holmblad. I'm the Riverside County Medical Association president. Welcome to our semi-monthly call with our public health officer, Dr. Cameron Kaiser. Before I ask Dr. Kaiser to provide a COVID-19 update and answer questions that have been posed by our membership, I want to thank Dr. Kaiser for his tremendous leadership during this pandemic and the forward-thinking public health stance he has taken to protect the public, our patients, and our healthcare providers. I strongly believe it was because of his strong directives that Riverside County did not experience the expected surge and has instead been able to manage and provide care for those who have been infected with COVID-19. Unfortunately, on May 8th, the Riverside County Board of Supervisors voted to rescind the public health order by Dr. Cameron Kaiser requiring face coverings and social distancing mandates through June 19th. Despite the requirement being lifted, Riverside County Medical Association strongly recommends the continued use of face coverings and social distancing to slow the spread of COVID-19. The RCMA will be making this announcement public later this evening. Physicians' offices as public places of business are encouraged to require face masks to be worn by all patients and staffs. Patients look to their physicians to provide guidance based on scientific evidence during this pandemic. Additional guidance will be included in the announcement we will send to all physicians later this evening. As a reminder, all lines are muted to avoid background noise. If there is time following the submitted questions, you can enter additional questions through the chat feature, and we will attempt to get those. With that said, I will now turn over the call to Dr. Kaiser for an update. Dr. Kaiser.
Thanks, Dr. Holmblad. Again, it's my pleasure to be with you this evening. I'll just go do a quick situation update before we get to the questions because we have quite a few of them. As you are all no doubt aware, our current cumulative count is 5,440 cases in the county, 235 deaths with 3,254 individuals recovered. When we say recovered, this is people whom the public health department has closed their case. They've either met test or non-test criteria. We actually have a few questions about that, but the long and short of it is we use the 10 days since the test as opposed to symptom onset, so that way we deal with asymptomatic individuals, as well as 72 hours being afebrile and with substantial improvement in their symptoms. The county, I think, if you've looked at other test levels throughout the state, we continue to be a leader as far as acquiring PCR testing. Our test rate is now up to 78,939. If you run that against our population, that's over 3%. We are actually doing some discussions about trying to get some general seroprevalence. Obviously, we want to make sure this is as statistically rigorous as possible, because most notably the Santa Clara studies have been attacked for having selection bias, and even the study designers have acknowledged this as a limitation. And also we want to make sure that the assay we're using does not have a poor specificity, because even a modest amount of false positives will significantly call the actual prevalence into question. We'll hope to have more information about that in upcoming soon. The long-term lookout is that we are working with the state at the county level to determine what level of reopening is appropriate for Riverside County. I'll have more to say about that in the questions a little bit later. But I'll just say personally, I do appreciate the position of RCMA. I have to always be mindful of the political ramifications, but I think it's fair to say that the board, even though the orders were rescinded, has chosen to implement a strong recommendation, and I appreciate the leadership of RCMA and other agencies in pointing out the medical benefits of doing so. Yes, masks are not a complete solution. Yes, it's one of a number of things that we need to be doing to try and reduce spread, but I think it's in many situations one that can provide enhanced protection even in an imperfect world such as ours. With that, I will hand it back over to you, Dr. Holmblad, and we'll go through the questions.
Thank you very much, Cameron. Question number one, Dr. Kaiser. What were the factors on which you originally extended the order to continue masks and social distancing until June 19th, 2020? With the rescission of this order, what are the specific guidelines and what do we tell our patients?
What might be best, Dr. Holmblad, why don't we take that with the second one, because they sort of go together.
Go for it.
The second half of that in the second question is, why has the county decided to lift the mask requirement? It does not seem safe for people to go without a mask, especially since there can be asymptomatic carriers. What advice do you have for clinics and other businesses? As I say, I have to be mindful of the political ramifications. So without wading too deeply into that, as mentioned, the board chose to replace the previously existing orders with an official strong recommendation. That being said, yes, part of the reason why the orders and now the recommendation exist is exactly because of the issue of asymptomatic carriers. There's also some reasonable evidence to suggest that the amount of spread which an asymptomatic carrier may be able to do may peak several days before the onset of symptoms. And I think that it's worth pointing that out to patients, even though we believe that asymptomatic carriers currently are not major drivers of outbreaks. Nobody really knows that for certain. I'll just say personally that I wear a surgical mask when I am seeing patients, including the N95 mask that I would normally wear for seeing communicable patients. And at all other times when I'm in stores or the administrative offices, I'm using a facial covering, and I continue to recommend to my own patients, especially if they're out and about in public, to strongly consider it given that concern, and that physician offices and hospitals should do the same.
Okay. I think then question number 3, is Riverside County doing rigorous contact tracing on all new positives? If no, why not? If yes, why aren't you sharing the information with the public?
The answer to contact tracing is yes. This is even a state requirement. Earlier this week, the state demonstrated that their forthcoming comprehensive system, they're contracting with Accenture and a couple other groups to actually have a comprehensive contact tracing application. It will even do mobile outreach. It has full case files, connections between them. It should be a very comprehensive product. It was actually rather complex to use, but they promised some good training on it, and it will be implemented at no cost to the county, which is always a plus. The last part of the question, I'm not sure exactly what was meant by information, but I will say that naturally anyone who is at risk, and anyone who's ever worked with us on a TB exposure, you can attest that the department generally has an extremely conservative definition. We will be contacting them. Beyond that, though, contact tracing, and it's really a basic public health intervention. We do it for years with lots of different things. And it's taking a really unjustified black eye. People are starting to mischaracterize it as some intrinsic invasion of privacy. I'm not really interested in providing more grist for that particular mill, but we will certainly be contacting anybody who is detected as part of a contact tracing. We are making it public that we do this. This is a standard practice. We would do it for any other communicable disease. I don't see why we wouldn't do it here. And in fact, should the county get to the point where it will be submitting a formal attestation, and this will hopefully be occurring soon in accordance with the statewide reopening plan, our contact tracing plans will actually be necessarily made public as part of that document. And we intend to let the public know that, no, this is not something they'd be scared of. Yes, we will do it in a privacy conscious fashion. And yes, we will get to the bottom of it to make sure that any individuals who are at risk are promptly identified.
Okay, thank you. Question number 4, what are the thoughts on the number of cases that continue to grow in the county versus deaths and hospitalizations, which seem to be somewhat stable?
The hospitalization question seems to be, at least in part, an artifact of people staying away from EDs and urgent cares. I imagine that if an individual showed up at the hospital with symptoms and they were COVID positive, there'd be some concern about their admission. I will note that there's been a recent uptick in the last few days, although we get these periodic blips, so I'm not really sure how statistically significant it is. But it is clear that our emergency rooms are going heavily underutilized, particularly by those patients who would, without PMDs, who would use those settings for primary care purposes. I am not sure, however, that I would characterize our deaths as particularly stable. If you look at our numbers, there's been over 85 in the last 14 days. The larger question, and the one I think this question is trying to get at, is whether the medical opinion on how dangerous the virus is changing based on an increasing case rate. Our crude case fatality rate based on the numbers at hand, and as I mentioned, today's case number is 5440 and our death number is 235. You do a simple ratio and you get something of about 4.3%. Now keep in mind that even with the asymptomatic testing that we're doing, and we were one of the first counties to actually offer this, there are almost certainly more undiagnosed living individuals and undiscovered deaths. So that 4.3% is undoubtedly an upper bound on the case fatality rate. But that being said, the value hasn't changed a great deal in the past few weeks. It seems to be tracking something similar to that. We have a fairly aggressive case investigation unit. Our medical examiner has actually done some great retrospective work looking at previous cases and being able to do testing where appropriate. We have avoided doing testing on blood samples we were worried would be severely hemolyzed because we don't want this to affect our numbers. There's certainly lots of, skepticism that we're over-reporting. We're trying to use the same standards that we would use for flu. When we get a positive flu result on somebody who passed away, yes, certainly underlying conditions play a role, but you can't say the flu had nothing to do with it. And we take the same position for COVID-19. And we're also being very careful to remind people, there was a particularly vicious rumor that circulated that said that we received greater payments for COVID-19 or that somehow that COVID-19 deaths were being reimbursed. I have no idea where that comes from. Speaking as the county's vital records registrar, which is part of my work, the only thing I expect of physicians is just to simply write an accurate death certificate. That's all we've ever asked for. And we're paying particular attention to that because we want people to believe that our statistics are reliable.
Okay, thank you. Question number 5. We are planning for our staff to return to work as an essential business. Our administrative staff are located in a non-clinical area and are not in the same building where patients are seen. We do plan to implement physical distancing policies, but do we need to require our administrative staff to wear masks?
The county, as previously mentioned, has no specific requirements at this point, only recommendations. But the state has guidance for office workspaces, and I think that is what this would probably fall best under, including a formal checklist. Most of what you think should be in there is in there, including things such as considering symptom screens, cleaning schedules, social distancing, facial coverings. None of these things are necessarily prescriptive, but the state does require some level of determining a site-specific protection plan and a risk assessment. This does not need to be extremely formal. It does not need to be highly verbose. It just needs to hit the major points in the guidance document. The state recommends that you make it public, but they won't be doing an approvals process on it. You just need to find that balance that you think will work best for your staff, incorporating those best practices, and then proceed accordingly. The state's guidances, and again, like I say, the key word is guidance. They are all at the master state site at covid19.ca.gov. They have it subdivided by business sector. And for a setting like this, I believe that the office workplace would fall most under those guidelines. You'll note on that page, by the way, you won't see anything about physicians' offices. That's because CDPH has separate guidance for that on the CDPH website.
Okay. Question number 6. If we are using appropriate PPE, can we start seeing non-urgent patients in our office? It seems that we are better educated and equipped than the liquor store.
I would certainly hope we all are better educated than the corner booze hole. I am aware of no specific state limitation on physicians' offices seeing non-urgent patients. I believe that was considered a stage 1 essential service from the very beginning. Now, note that there is still substantial argument over droplet versus airborne precautions for COVID-19, but healthcare workers should at least wear at minimum a surgical mask for patient visits. CDC, and I think pretty much everybody agrees that cloth face coverings would not be sufficient in this case. And we strongly recommend that offices adopt this requirement for patients. It is perfectly right to point out that even an asymptomatic patient could potentially be a suspect, and this would make the need for an N95 in that situation really a judgment call. But a reasonable middle ground might be to use an N95 for patients with any respiratory symptoms and use surgical masks for others. And just to show that I'm putting my own lungs where my mouth is, yesterday every patient that I saw in person was masked, and I used a surgical mask with appropriate social distancing. Obviously, that's difficult to do with a physical exam, but we minimized that contact. I made sure I cleaned my stethoscopes after every patient, except, of course, for the patients that I saw in respiratory isolation, where I used an N95 because I would do so anyway. There are some alternative procedures for those of you who would prefer to be using an N95 all the time, which is not an unreasonable position. The CDC does have some additional guidance on using N95s for extended periods, rather than discarding it after individual patients for using it around 8 to 12 hours. That appears to be the upper bound. Do note, of course, that extended wear of an N95 is difficult even for those of us who are used to wearing them. Another one, and this one I think has more promise, is rotating between reused N95s on different days. This has been employed in some settings. Basically, you set out with 5 to 7 masks. Each of them are in a bag. You know, Mondays you've got a mask, Tuesdays you have a particular mask, Wednesday, Thursday, Friday, so on. You'd obviously need at least 5 to 7. This is predicated on coronavirus survival within the mask matrix having an upper bound of around 72 hours. So therefore, anything that would be trapped in there would be likely to be dead by the next time that you use that mask a week later. Obviously, you would not be able to use the masks indefinitely, but that may be able to extend your PPE usage by at least several times, particularly in a situation where you have a limited amount of it on hand.
Okay. Question number 7. PPE continued to be in short supplies for physician offices. What do we do? How can we begin seeing more patients without proper PPE? And where can we find N95s?
I think we skipped one, Dr. Holmblad.
Oh, okay.
On screen, you've got something about elective surgery and a recent test.
Okay, we'll go to that one. Should all patients for elective surgery be required to have a negative recent COVID-19 test?
I haven't found specific nationwide guidance, and the American College of Surgeons was not specific on this. I went and actually looked that up last night. The general recommendation, the one I'm hearing mostly from surgeons and anesthesiology groups, is that a negative PCR test prior to surgery is advisable. The good news is we have ample county capacity for this. If you are not able to do it yourself, you are more than welcome to send it through one of the county facilities. Now, keep in mind that depending on lab lag time, if you really need that result right away, it may be a little while before that happens. It may be a couple of days. But nevertheless, if that's not something that you have available to you or you're not able to get easily, the county, if they're a Riverside County resident, we are more than happy to see them for you. They just need an appointment before they do. If you go to rivcoph.org/coronavirus, and I think that's linked off the RCMA page, you can see all of our test locations and the 800 number to call. Alternatively, one other option that I've heard mentioned is that you could do screening on them, and based on that, a mandatory quarantine period. And the ACS does appear to list this as a possibility. But frankly, given currently available levels of test availability, to me, it would just seem simpler to test them. The bigger question really is what to do if they're positive and how you're going to clear them after that. Again, for the county, we are using modified non-test criteria. As I mentioned when I was discussing our recovered numbers, we've chosen to be slightly more restrictive than the CDC standard. We're going 10 days after the date of test. Again, assuming they were never symptomatic in the first place, or if they were, that they have been afebrile with substantial improvement of respiratory symptoms for the past 72 hours. The anesthesiologist may be well within their rights to demand that they be completely asymptomatic. Some facilities are doing this. I don't see a problem with that. If you do decide on the higher standard of 2 negative tests 24 hours apart, be advised you may be waiting several weeks in some cases for clearance. And we have had the situation, and this is why we've tried to avoid using a test-based strategy, but we have done it in a few circumstances, especially where we believe that symptomatology was not reliable. In those cases, we did pop a couple negatives, and then they went back to positive. So the false negativity rate of the PCR test then gets called into question for something like that, which is why I think the clinical clearance is much more useful, but you can do it that way as well.
Okay. Question number 9. It has been suggested that we should consider all patients COVID-19 positive. If that is the case, what are the guidelines for PPE for patients and medical staff and providers? Are there different guidelines depending upon specialty?
Well, first, let's talk about PPE availability. The county has been doing some very large PPE buys, and actually, very early on, when we were doing this calls, we were essentially limited strictly to tier 1, which would mean EMS providers, hospitals, and the like. While our patient offices, and sorry, this is just the way it has to be, are obviously lower priority than those, we actually are now able to start filling some of those requests. Now, I would want to remind people on the call that you may not and probably will not get everything that you request. And you are still expected to make every reasonable attempt to source and maintain a PPE supply chain yourself. I ran this question by the emergency management department, and they wanted to make it very clear to me, so that I made it very clear to you, that the PPE system is intended as mutual aid, which is to say that practices and institutions who participate should also be prepared to contribute into the system should PPE stocks again become impacted. With that in mind, if you understand that this requirement and you do have an urgent PPE need, we actually do have an email request for that, and it is MH-resource, MH and then the word resource, RESOURCE @rivco.org. That goes directly to our Medical Health Operational Area Coordination Program. In whatever email you send to that address, please be very detailed about what you require and over what time frame you expect to need it. We can help you with things such as gowns, gloves, N95, surgical masks, things like that. Again, like I say, you shouldn't accept it as a guarantee that you'll get everything you ask for. You may not get necessarily most of what you ask for, but we will try to satisfy those requests, assuming, of course, that all reasonable efforts have been made to source it yourself. And I understand that PPE is still very thin on the ground, and we appreciate that. We've had a number of very large deals that the county has tried to engineer that have turned out, frankly, to be fraudulent, or somebody swooped down and took the stuff. We've managed to get our money back in those cases, but that, of course, has been detrimental to our supply. With that in mind, the CDC does not necessarily have recommendations for PPE usage based on specialty, merely that aerosol generating procedures, and that, those occur with what you think might be happening, NP procedures, obviously things like bronchoscopy, stuff like that, must use full PPE with N95, although I would imagine those situations you'd probably do so anyway. And then other situations the supplies warrant. But again, as I mentioned, N95 is still the preferred standard in most settings for suspected patients because of that persistent debate on droplet versus airborne precautions. And now that there are generally acceptable guidelines for extended use or recycling practices, these don't require special sterilization equipment, and I think would be an option that many physician offices could easily implement. Nevertheless, as I say, an increasingly common middle ground, and the one that I'm using personally in my practice, is to use a surgical mask with asymptomatic patients, again with appropriate social distancing where possible, and then to use N95s for higher risk patients who are symptomatic and have an exposure history. And then in my particular case, I'm also trying to do extended use of those N95s so that we have them available for the patients who are on respiratory isolation.
Okay, thank you. Question number 10, can you provide more information on COVID-19 and what is being discovered with children? What are the plans for schools reopening?
Of the orders that were previously in effect, the only one that remains is actually the K-12 closure order. We also eliminated the higher education component of that order was also limited by the board's action. Part of this reason was because the order that I issued locally actually is substantially more specific and in greater provides more detail to school districts than the statewide order. And this is no surprise because, frankly, we tried to work with them on it. There is quite a lot of concern about the impact of pediatric COVID-19. That said, further extension versus allowing it to expire, this is being discussed but has not yet been decided. Now, I will say for the record, the preliminary data that we do have suggests that kids seem to get it at about the same rate as everybody else. But they have fewer adverse effects, and none of this will probably surprise any of the pediatricians on the call. There was some early concern that they may be more prone to GI manifestations. So far, I don't have enough data locally to correlate this. And we have been fortunate that we have not observed any of those so-called Kawasaki-like multi-system inflammatory syndrome cases. We haven't recorded any of those here. But again, our number of pediatric tests is also quite low. If you look at our county coronavirus site, you'll notice that a number of cases in the pediatric age range is small. This is primarily a testing artifact because kids just aren't being tested in the same numbers that everybody else is. Part of it is because their symptoms are usually minor to clinically inapparent. I always point out, find me a 5-year-old who doesn't have a runny nose and go on from there. But we are making open requests to getting more kids through the testing locations. All ages are welcome. And we will be presenting some of this data to the county superintendent's office when I get it cleaned up. In particular, I'd like to try and correlate this with any kids who may be ending up in the recovered pile. Now, this is a largely manual process, so our epi groups are working full time on it. Either way, we will present this to the superintendent's office, and the decision to reopen will likely occur at the district level in coordination with the State Office of Education. Governor Newsom has been on record as saying he thinks that the schools may open as early as July. Seems a little optimistic to me, but hey, he's the governor. We'll just have to see how that all pans out. But as far as epidemiology in that population, kids are not magically immune. It just doesn't seem to affect them all that much.
Okay, question number 11. If not already covered, what is the most important thing physicians should know or do when communicating with their patients and their concerns over COVID-19? What should be our message to the public from the physician community?
I think the best message to be made to the public is please take all of this seriously. There is an absolute mountain of disinformation out there. I mean, there's obvious dreck like pandemic to every armchair epidemiologist out there who doesn't know the difference between mortality rates and case fatality rates. But I also want to make it clear that taking it seriously doesn't mean that we shouldn't reopen. I get the economic case. My folks were small business owners, and this whole thing would have flattened them if it had hit a decade ago when they were still running it. And I certainly agree that there's a good case to be made at some level that the lockdown becomes economically worse than the disease, and losing jobs and livelihoods also has a negative impact of public health. But the political polarization of COVID-19 has now reached such a fever pitch, if you'll pardon the pun, that if you wear a mask, people say you're a communist, and if you want businesses open, they say you're going to kill grandma. In my view, neither position has to be mutually exclusive. I think that we need to consider how that we can reopen and get some of these sectors or businesses open, but I want to do it in as safe a means as possible. Frankly, I think that it's going to be a competitive business advantage that businesses have a strong requirement on facial coverings and social distancing coming in through the door. I mean, just speaking personally as a consumer, I know I would demand it. I'm sure many of you listening to this call would say the same thing. I would like to know the business that I'm walking in is not only taking care of their employees, they're taking care of me. Frankly, we're going to reach a point where a vaccine is still way off in the future. Much as we've seen with the flu vaccine, it turns out to be extremely difficult to do effective vaccines for upper respiratory tract infection. But we may not be able to stay underwater much longer. And if it comes to a point where we can't, then we're going to have no choice but to figure out how to live with it. And if people don't take this seriously, then we really will have more deaths. We will have less consumer confidence. And as a result of both of those things, we're going to see even more personal and societal consequences. And I really think that if we don't take an appropriate, well-reasoned middle ground to looking at this, that's going to be something that we could have avoided.
Okay. Dr. Kaiser, Dolores has a few questions for us from, if you still have some time to answer here.
Yes, I think we've got a couple, so yeah.
Yeah, yeah. Dolores will throw you the questions.
Oh, okay. Thank you, Dr. Kaiser. I think the first question you answered, but I'll see if you have anything else to add to it. Are we seeing any PMIS in any pediatric patients in the county? I believe you answered that, but. No. Can you hear me? Oh, okay. Just a minute. Sorry. I'm going to mute.
I got it. No, we have not seen any such cases. We're certainly watching for them because they're quite spectacular. And I have no doubts that if we got one in any of our pediatric settings, we would be the first to hear about it, but I have not received any reports of it.
Okay, thank you. Can you repeat the email address where we can get PPE?
Yes, that email address again is MH, that's medical health, MH, resource, RESOURCE, MH resource, all one word, at rivco, RIVCO.org. And it'll be in the notes from today too. Dolores, I'll send you those.
Great, thank you. And RCMA will put that in our resource center too. Thank you. The next question, is there a limit on employees per office?
Not specifically. Many of you will recall that the previous orders that I had in place, it seems like a lifetime ago, but this was 2 months back, did have an occupancy limit. That is no longer generally the case. It's been replaced with simply making sure that appropriate social distancing is there, which you can achieve lots of ways. You could achieve it through airspace. You could achieve it. Some places are doing it with plexiglass panels. As long as they're rigid and impermeable, that would be another way to do it. I consider that to be just another wall. Again, the state guidelines are just that, guidelines. No one will be checking your plan. No one will require you to submit it anywhere for approval. But the key is just to avoid cramming in too many into that space, whatever that happens to be for the available volume.
Okay, thank you. And Dr. Holmblad, before I turn it back to you, I just want to make a comment on the last two. We were asked 2 questions regarding telehealth billing. And so we do have a reference on the screen that you're seeing that obviously that's not a Dr. Kaiser question, but the RCMA is happy to answer that. We could not determine who submitted the question. So if you will send your question to Mitzi Young, our physician advocate, and you'll see her email address there, and she would be happy to answer the question. But these questions are also addressed in our telehealth billing guide that is on the RCMA website, and anybody can look at that for a lot of resources. So at this point, Dr. Holmblad, I'll turn it back to you.
Well, I just want to summarize here. Thank you, Dr. Kaiser, for answering our providers' questions. Once again, I appreciate your leadership on this. Personally, I feel myself and my family is much safer because of the things that you have done for our county.
Thank you, Dr. Holmblad. That's very kind of you to say.
And for everybody else, I wish you a good night. Thank you.